Okay, so actually how we conduct courses are that we give you small recordings of all the topics. Okay, so whoever my core students are here, they have already gone through the video sessions of all the malignancies, right? So all the topics, that is vulva, cervix, pre-malignant lesions, cervical screening, ovarian cyst. So they have already gone through the video lectures of these all topics. See, they are around 30-40 minutes videos, for one video for every topic. And I have already given them the links and they have gone through it. Okay. So therefore, we do not discuss lot of theory in our live sessions because already the theory has been covered. So this session is going to be a completely interactive session in which we will be discussing questions predominantly from the Stratog. And whenever for any particular topic, I find that Stratog does not have adequate questions to discuss that topic, then I take question from other sources, right? Otherwise, it is predominantly a Stratog session. And we are going to do a brainstorming on these questions so that we are well prepared for the brainstorming in exam. This is the purpose of doing this live session. Okay. So when you are going through this live session, I'll be talking of questions and you all can write in chat box or you can unmute and give your answer. And we are going to discuss about all the confusions. Simultaneously, we will be discussing on all the important rules pertaining to whatever topic we are doing. So today we are going to cover vulval carcinoma, endometrial carcinoma, ovarian cyst, and ovarian carcinoma. Right, the rest of the topics of this module we have already covered in our live session 1, which we took on the Friday, right? So let's start session. And I'm looking forward to good participation from all of you. So all of you, please try to answer the questions because this is a place where you can actually clear all your doubts. If you make a mistake here, you will remember very well in the exam. This is what I always tell in the Telegram groups also. So please do try to answer, right? Dr. Kiranmesh is not able to listen. So I think maybe the issue is with her network. We are fine. I think all of you, I'm audible. I'm audible to everyone, right? Yes or no? Yes. Okay, yes, fine. Thank you, Dr. Dhara. Yeah, thank you. Okay, so let's start our session. So this is the first question. So 75-year-old woman presents via an urgent referral with a 4-month history of vulval pain. So we have to keep marking the points. 75-year-old woman, urgent referral with 4-month history of vulval pain. On examination, she has 4 centimeter irregular exophytic tumor replacing the clitoris and extending to within 15 millimeter of urethra. So this is largely a central tumor. This is replacing the clitoris. And large lymph nodes are palpable in both groins. What is the next most appropriate step for this patient? Perform CT scan of the abdomen and the pelvis, simple vulvectomy, urgent radiotherapy, vulvectomy and bilateral inguinofemoral lymphadenectomy, wedge biopsy of the lesion.
Ma'am, wedge biopsy of the lesion to make a diagnosis.
Yeah, okay. So wedge biopsy is one answer, and in the chat box there are E. Anybody would like to go for any other answer? Everybody is fine with wedge biopsy? So absolutely correct. It's an absolutely correct answer. So basically we have to do the wedge biopsy. Why we have chosen this? Because right now, on examination, it seems that it is a vulval carcinoma, but we haven't done any histopathology. Unless and until we prove this on the histopathology, we can't say that this is carcinoma. And by that time, we cannot even stage and we cannot plan a further treatment. So wedge biopsy of the lesion is the first thing which have to be done for this patient. 75-year-old woman is seen in urogynecology clinic complaining of pelvic organ prolapse. Of note, there is a history of intermittent steroid cream use for a sore and itchy vulva. On examination, there is a warty lesion on the vulva that is 1 × 1 centimeter on the left inferior aspect of labia majora. What would be the most appropriate action here?
Ma'am, D.
Okay, first I got two answers in the chat box, A and D, and I heard somebody saying B. So A, D, and B. Now I have three answers. Another D, another D.
No, ma'am, D.
A,
D.
D. Okay, so A and D. I've got two answers. Still A are coming up in the chat box. So I have A and D. D. Okay. So those who are choosing A, why they want to choose A, and those who are choosing D, why they want to choose D?
Ma'am, D because she is 75 years old. She has itchy vulva and there is a warty lesion. So we have to make a diagnosis. If it would have been incisional biopsy, then we would have chosen that. But because that is not in the option, then the other option is to refer to the gynae oncology clinic. That's why we chose it D.
Yeah, okay. And why A? Those who chose A, please, anybody can you give your explanation?
To rule out malignancy, ma'am.
To rule out?
Malignancy.
Okay. Okay, fine. So to rule out malignancy, we want to do the biopsy. Okay. So what is the preferred biopsy done in the vulvar lesions?
Keys, punch biopsy or incision.
Yes. So that is Keys punch biopsy. Basically, that is what we are using. And it is a type of incisional biopsy only. We are taking a punch, right? So that is basically, yes, you are right. If it is in this place, it is incisional, then we can choose biopsy. But they have given excision biopsy. So excision biopsy is never a correct thing to do, because if you completely remove a lesion and then your margins are not clear, or you want to do further something, then you are not clear about it. So excision biopsy is never a preferred thing to do. D is the correct answer. Refer to dedicated gynecology, oncology, vulval clinic for an opinion. This is right, right? Now, this is right because if you have gone through the RCOG vulva CA guidelines, it is clearly mentioned that any postmenopausal woman with wart is a malignancy. Okay, there are no warts in a postmenopausal woman, which are because of HPV, right? So a wart in a postmenopausal woman is a malignancy, right? So even if you have the incision thing also here, still you have to refer this patient to dedicated gynae onco or vulva clinic for an opinion, right? Because it is clearly written as a rule that any postmenopausal woman with what refer to gynecology clinic or the dedicated cancer clinic, right?
Yeah. Ma'am, I have a doubt in this question.
Yes.
Ma'am, can you show the question, please? Ma'am, in this question, there is written that there is a history of intermittent steroid cream use for sore and itchy vulva. What is the significance of this line? And my second doubt is, if incision biopsy is given and D option is given, what to choose above the other? Incision biopsy or directly refer?
Okay.
These two.
Yes. So first doubt is intermittent steroid use, sore and itchy vulva. It is just a distractor.
Okay.
If you just go through the RCOG questions, there are very fixed rules which they ask you. All the other information given in the question is actually not of much use. So what you have to practice is you have to pick up that one line which they are asking. Like I told you, postmenopausal women do not have any warts due to HPV. If they have warts, that's a malignancy, right? This is clearly written in guideline of vulval carcinoma, right? So that is the point which is tested here. So whenever you answer a question, take out that one point which is tested in that particular question, okay? Because the points which are tested will remain same. Scenario will vary. Scenario will keep on changing. Women will change. This medication will change. They may write you that she has used imiquoid or ye or wo. So these things will change. But the rule, the key line around which the question is revolving, that will remain the same. So the main crux of the information here is postmenopausal women with what is a vulval carcinoma. So in that case, of course, therefore, they have not given you the option of incisional biopsy here, because then it will be two answers will be correct. Therefore, they have given you the option of excisional biopsy. But if at all it is there, then refer to dedicated gynecology, oncology, or vulval clinic is the correct answer as per vulval carcinoma guideline.
Okay, ma'am.
Right? Did I answer your question?
Yeah, so incision biopsy should not be the first thing. First is refer, they will do the incision.
In this particular scenario, not always. If this is a scenario of ulcer, yes, we'll do first, or there is a hypertrophied lesion, indurated lesion, then yes, we'll do first incisional biopsy, we'll confirm a diagnosis and we'll refer, right? But warts for warts, they have specifically mentioned this line.
Or refer, then incision. Okay, ma'am. Thank you.
Okay, so this is about
Excuse me, ma'am.
Yeah.
And ma'am, if it is not vaulty lesion and if it is suspected pre-malignant lesion, like we have read, we have applied steroid cream and it doesn't respond. And then we used to refer that patient to the vulval clinic. But before that, we can take biopsy.
Yes, of course. See, what is the care pathway for the vulva? What is the first level? First level of care for the vulva? GP. Very good. So if a patient is having any symptoms, itching, pain, she will go to GP, right? So now after that, GP does not find any good option, no allergies, no anything else, refers to the general gynecologist. No, general gynecologist, right? Okay. Simple gynecologist. She can offer her clobetasol or creams. If she does not get better, she can do vulval biopsy, right, to confirm her diagnosis. And then if she finds that this is lichen sclerosis, but it is not getting better, she needs to put her on the imiquoid. Then she is not the one to put her on the imiquoid. That will be done in the vulval clinic. Similarly, VIN, once diagnosed, patient will move on to vulval clinic. Vulval carcinoma, of course, will go to vulval clinic. But vulval carcinoma, high degree of suspicion, like we said in warts, patient can be directly referred to vulval clinic without doing any biopsy. So biopsy can be done by a general gynecologist, and that can be done at a vulval clinic also. So this is the care pathway for the vulva. So we need to know what we can do. We can offer clobetasol, we can do vulval biopsy. Right? Any more confusion?
Ma'am.
Okay.
First is biopsy, then imiquoid, or first is imiquoid, then biopsy? First is
biopsy. First you confirm that this is a lichen sclerosis, then it is imiquoid.
Okay.
If patient does not respond to clobetasol, you have to confirm that this is lichen sclerosis. That will be done by doing biopsy. Once confirmed that this is lichen sclerosis, then you can put her on the imiquoid. Not you, but vulval clinic can put her on the imiquoid.
Okay.
Okay. Okay, great. So there is something in the chat box. Steroid causes immunosuppression. Okay. So do you mean to say that the steroid can lead to VIN? Is it something like that? I couldn't get what you want to say by this. You can unmute and speak if you want to ask something specific.
No, ma'am. I want to say that if she is using steroids, then steroid can lead to immunocompromised state as well. And at the age of 74, so it can lead to cancer as well as HPV.
See, if you are doing giving steroids for the lichen sclerosis or something, then it is just a 3-month course. You are not going to put her indefinitely on the steroid, right? So therefore, and then if there are intermittent multiple courses, then also not much related to development of carcinoma because of steroid, right? So that is predominantly a distractor, nothing else. Okay. Next question. You are about to see a 60-year-old woman at the vulval clinic. She initially presented 2 weeks ago complaining of soreness and irritation of the vulva. On examination, there was a 4.5 centimeter ulcerative lesion at the left anterior vulva involving clitoris. Punch biopsy now has been done, and that reveals squamous cell carcinoma. In addition to radical excision of the primary lesion, how will you counsel her regarding lymph node management? Very easy, direct question. Everybody is right. A. Yes. Good. Yes, everybody is saying A, and I do agree with you all. A, because this is a central lesion. So we need to do the bilateral inguinofemoral lymphadenectomy. Why not sentinel node?
It is more than 4 centimeter.
Good,
4.5.
very good. It is more than 4 centimeter. So we are not choosing the sentinel node here. So therefore, A is the correct answer. Bilateral lymphadenectomy. 65-year-old woman was referred with soreness of vulva. On examination, there is a raised irregular lesion with an erosive appearance measuring 1 centimeter in diameter. What would you do next? Obtain a representative incisional biopsy, perform a wide local excision, refer to cancer center, request a groin ultrasound scan, and request MRI. A. Correct. So now if you look at this question, you can compare this question with the question which was talking about the what, right? So here we are choosing incisional biopsy, right? Because this is raised irregular lesion with erosive appearance. So suspicion of cancer is there. So we want to confirm and make a diagnosis with the help of incisional biopsy. So this is obtain a representative incisional biopsy. That is correct. 70-year-old woman presents with a 3.5 centimeter into 4.5 centimeter raised irregular fungating mass of the left labia extending to the clitoris. A representative biopsy of this lesion has confirmed a moderately differentiated squamous cell carcinoma of vulva with a depth of invasion 8 mm. What is the most optimal management plan for this woman? Okay, quick answers B. Everybody wants to go with B. So radical wide local excision and bilateral groin lymphadenectomy. Right. It is absolutely correct answer. Now my next question is when we will not do lymphadenectomy. What group of patients we do not require lymphadenectomy?
Stage 1A
Hmm.
and
Melanoma,
basal carcinoma.
basal cell carcinoma, and verrucous carcinoma. Verrucous
Carcinoma, verrucous carcinoma, stage 1.
And when lymph nodes are positive, when lymph nodes are palpable, then also we don't do lymphadenectomy.
Then to pura treatment will be different. In those cases, treatment will be different. that is absolutely a different thing, right? So basically 1A, verrucous basal cell carcinoma and even malignant melanoma. Yes, we do not do lymphadenectomy in these lesions. Correct.
We will only local excision.
So, can you please mute? Huh. The most important prognostic factor in vulval cancer is groin lymph node involvement. Depth of invasion of tumor is an important predictor of groin node involvement. Tumor size and location are also predictive of groin node metastasis. Surgery is the mainstay of treatment for patients with vulval cancer. Radical wide local excision of primary tumor with minimum margin of 15 millimeter of normal tissue is sufficient. In lateralized tumors, ipsilateral groin lymphadenectomy can be performed initially. In unifocal tumors less than 4 centimeter in size, patients can be safely managed by removal of identified sentinel lymph node. Groin node dissection can be omitted in stage 1A tumors, which are less than 2 centimeter in size and depth of invasion less than 1 millimeter. You are carrying out a service improvement project within the postmenopausal bleeding clinic setting. You need to have an idea of approximately how many new cases of cancer will be identified among the population of women being referred to this clinic. Which of the following represents the percentage of women with postmenopausal bleeding who will be found to have an endometrial cancer? Very, very easy and direct question. Everybody from the part 1 also know this. A, 10% is the correct answer. Correct. Okay. So which of the following combination of characteristics most accurately represent a case of type 1 endometrial cancer? 52 years of age, BMI 37, perimenopausal, endometrioid, low grade and good prognosis. 54 years of age, BMI 23, perimenopausal, serous cancer, low grade and good prognosis. 55 years of age, BMI 28, postmenopausal, serous cancer, high grade and poor prognosis. 71 years of age, BMI 44, postmenopausal, clear cell cancer, low grade, good prognosis. 76, BMI 32, postmenopausal, serous cancer, high grade and poor prognosis. A, good. A. Good. A. Yes, A is the correct answer. Because why it is so? Because age group, perimenopausal, 37 BMI, obese patient, then endometrioid cancer, that is type 1 cancer. It is low grade and good prognosis. So this is correct. Why not others? This is not obese patient. Serous cancers, they are non-endometrioid. Again, serous non-endometrioid. So these are all non-endometrioid. So the first one is the representative case of type 1 endometrial cancer. Any role of BMI? Yes, BMI role is there. Whatever factors, whatever risk factors are there for the endometrial carcinoma, which work through hormonal pathway. Obesity works through hormonal pathway. Because of the peripheral conversion, the estrogen levels are high. So therefore, there are more chances of carcinoma, endometrial carcinoma in obese women. So therefore, BMI is important and therefore they have given you a high BMI in this representative patient. Obesity is high risk. Undifferentiated serous papillary clear cell are high grade. Yes. So these are basically serous carcinomas are non-endometrioid carcinomas. So all these serous cancer clear cell, they all belong to type 2 cancers, which are non-endometrioid. So A is the correct answer. Fine with everyone? Any confusion? Okay. So we move on to the next one. So following are the FIGO stages for endometrial cancers. Allocate them appropriately to the 4 clinical scenarios. So histologically proven endometrial cancer, radiologically confined to the uterus, treated by standard hysterectomy with bilateral salpingo-oophorectomy. Pathology of the specimens showed an endometrioid carcinoma confined to inner half of the myometrium. However, peritoneal washings were positive. 1A, 1A. Okay. Yeah. 1A, 1A, 3A. Okay. No role of positive perineal washings. Okay. So we have two answers now, 1A and 3A.
Ma'am, it should be 1C now.
We are going to discuss about it. You can answer your question. So 1C, right? So we have 1A, 3A and 1C. Okay, so let's come to the point. So here the main distractor which is causing you to go in a wrong direction is peritoneal washings were positive, right? This is the one factor which is actually motivating to bring out more answers, because otherwise it is clear that there is endometrioid carcinoma which is confined to inner half of the myometrium. So if you just read up to this statement, everybody will go with 1A, right? Now, when it comes to be peritoneal washings were positive, then the confusion starts. So for endometrial carcinoma, peritoneal washings just mean poor prognosis for that particular stage. But peritoneal washings does not change the stage of carcinoma, right? So this is what we have to remember. In case of endometrial carcinoma, the peritoneal washings does not change the stage. It just means that there is bad prognosis as compared to the patients in the same stage who don't have positive peritoneal washings. Okay, so stage will remain same and no role of peritoneal washings. Fine, everyone agrees to that?
Yes, ma'am.
Okay, great. Now coming to next question. At time of hysteroscopy, abnormal lesions were found in the uterus, at the cervix, and also in the upper portion of vagina. An MRI scan did not show any pelvic spread otherwise. Biopsy of these lesions showed adenocarcinoma consistent with endometrial origin. Now what? So now it is 3A, stage 2. Okay. 3B. Fine. 3A. 3B. 2. Stage 2. Okay. So predominantly we have got three answers. That is 3A, 3B and stage 2. Now I want to ask, what is there in stage 2 endometrial carcinoma?
Ma'am, cervix, cervical stromal involvement.
Yes. So it is cervical stromal involvement. So here we are talking of vaginal involvement, right?
Yes.
So we said cervix and also on the upper portion of vagina. So can't be stage 2, right? Now, what is stage 3A?
A is, I
Ma'am,
guess,
Firoza and
parametrium. I'm little confused with A. A is, I think, parametrium. B is vagina. Upper
Yes.
vagina.
no, 3A
No.
and adenixa, 3B is vaginal parameter.
Okay, okay.
So 3A is serosa or adenixa, right? So 3A
Yes.
is serosa or adenixa and 3B is vagina or parametrium. And then 3C is when lymph nodes get involved, right? So this is 3A, B, C. So first stage is confined to uterus. So in that we have 1A and 1B, 50%, less than 50% of myometrium and more than 50%. Where in stage 2, we have cervical stromal invasion. Then in stage 3, we have A, B, C. A is for serosa and adenixa. B for vagina and parametrium, and C for lymph nodes. So this particular is 3B. Right?
Yes,
Makes
ma'am.
sense? Right.
Yes, ma'am.
Okay, great. So, if MRI shows pelvic nodes, then 3C. Yes. Now, in the all VPGO classifications, now they have updated that if the your imaging techniques show, then it is yes. Poorly differentiated endometrial carcinoma with invaded more than 50% of myometrial thickness. So we just now discussed. I think it should be an easy one now. One B, 1B, 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 1B. I think nobody will have confusion in this. So it is more than 50% of the myometrial thickness. So this is 1B. Correct. Absolutely correct. Well-differentiated endometrial cancer treated by simple hysterectomy and is found to have a large pelvic lymph node, which is sampled and is found to contain metastatic cancer. No other evidence of distant metastasis is found. Now what? 50% is stage 1B, yes. Less than 50% is stage 1A, 50% and above is 1B. 3C, 3C1, okay. Correct. Yes, it is correct. 3C and that too 3C1 because this is pelvic lymph node. If it is para-aortic, then it will be 3C2. So this is pelvic lymph node. So 3C1 is the correct answer. Fine. All good with everyone, right? 51-year-old woman presents with 2-month history of postmenopausal bleeding. Her period stopped last year and she has been using continuous combined hormone replacement therapy for 9 months. Transvaginal ultrasound scan revealed a normal size anteverted uterus with normal ovaries and an endometrial thickness of 3 mm. Clinical examination was unremarkable. What is the most appropriate management? Cervical smear, change to cyclical hormone therapy without performing further investigations, endometrial biopsy, inpatient hysteroscopy, and to cease hormone replacement therapy and investigate further if symptoms go beyond 6 weeks. E. Okay. Fine.
Ma'am, should be.
Everybody wants to go with E? Okay, not sure E, right? Any other answer or everybody is okay with E? Why not C? Okay, we'll just discuss why not C. And maybe it is C. C, okay, then there is another answer C. Yes, I'll explain, don't worry. But I'm just, see why I ask you to come up with all the options. Whatever you are thinking in your mind, because we need to clear why you are thinking so, because it is everybody is the same, right? Today any person is thinking about any option, second day same person would be thinking of another option, so everybody is same. So we need to clear our confusions, right? So we have B, C and E, 3 options. Okay, so now endometrium is 3 mm, so biopsy not required. Okay, yes, you are correct. So we look at the scenario once again. This is 51-year-old woman presents with 2 months history of postmenopausal bleeding. Her period stopped last year and she has been using continuous combined therapy for 9 months. So she is on continuous combined hormone therapy for 9 months. If you remember, usually these hormonal therapies, they are either given in the cyclical way or you give them in the continuous way, okay? In continuous replacement therapy, since this patient has not been long on a postmenopause, it is she's very near. Just last year it has stopped and for 9 months. So we even don't know that it is 1 year or not. So therefore, she is actually not completely like postmenopausal. So you have to consider her like a perimenopausal. So what good therapy for her would be? The cyclical one, right? But in this case, the good thing is that the endometrial thickness is appropriate, 3 mm. So that rules out your biopsy options. Endometrial biopsy and inpatient hysteroscopy is ruled out. Because normal size uterus endometrial thickness is 3 mm. So you rule out biopsy. Cervical smear, of course, is not going to give any answer, and clinical examination was unremarkable. So not very helpful. Now we have only B and E option in our mind. Okay. So change to cyclical hormone replacement therapy is not going to help. And otherwise also, after 50 years, you don't want to go for the COC at least. So this is not a good option. So it is better to cease the hormone replacement therapy and then see if hormone replacement therapy is the culprit for this bleeding, then that will settle down. And then after 6 weeks, you can investigate the patient if her symptoms persist. So therefore, the correct answer in this scenario is E. So endometriosis 3 mm, that was the previous remark. Okay. So let's read the answer here. The correct answer is to cease hormone replacement therapy and investigate further if symptoms persist beyond 6 weeks. Continuous combined HRT preparations are not suitable for use in perimenopause or within 12 months of the last menstrual period. Women who use such preparations are likely to suffer irregular bleeding and should consider changing to cyclical HRT. In this case, the bleeding is likely to be related to HRT use. So if following cessation of HRT, bleeding persists beyond 6 weeks, then we can go for further assessment. Otherwise, assuming the bleeding stops, the preparation should be changed to cyclical preparation. But first, you need to stop and see that it is because of HRT and remain assured about it. And then if she further needs, then you can give her cyclical. Because she is very near to the menopause, not yet just gone beyond that complete period. She is still in a phase of like perimenopause. Okay, clear? Okay, fine. 65-year-old woman with a BMI of 40, early menarche, late menopause, and type 2 diabetes mellitus presents with postmenopausal bleeding. The exit cervical cytology was normal. She has previously had a cone biopsy and is known to have cervical stenosis. An ultrasound scan of her uterus reveals an endometrial thickness of 20 millimeter. Both pupil biopsy in the clinic and general anesthesia, hysteroscopy, and biopsy were unsuccessful due to cervical stenosis. What further steps would you discuss with the woman? B. Anybody with any other answer except B? Or everybody wants to go with B? All high risk factors, yes. Good. Yeah. Okay, there is another answer. That is A, MRI of the pelvis. Okay. C, oral progesterone. Okay, so I have A, B, and C. Okay, so we need to look at these options one by one, right? So let's look at the scenario once again. 65 years old, BMI 40, early menarche, late menopause, diabetes. Now you see how they have built up a scenario. One after another, they have put up a risk factors, many risk factors, right? Obesity, early menarche, late menopause, type 2 diabetes, all are risk factors. And then they are saying that you can't take the pimples, and you even tried doing under GA hysteroscopy and biopsy. Endometrial thickness is 20 mm, right? So if you do the MRI of pelvis, what do you expect in this patient? What benefit MRI can give you? Spread, actually, right now we are not looking at spread. Right now we are looking at diagnosis, right? So how do we deal with the endometrial thickness? We want to look at whether it is atypical hyperplasia or without atypia, or it is carcinoma. So whenever a patient has endometrial thickness, endometrial hyperplasia, this is what we want to look at, because accordingly we will go with the further treatment options, right? So can MRI help you in differentiated between the atypia, without atypia, or carcinoma? No, MRI can't help you in judging this. So therefore, no use. Oral progesterone, can we give oral progesterone without looking at what is the scenario? No, again, we can't do that. Repeat cervical cytology is not going to help. Weight loss regime, of course, is required, but that is not going to solve the problem. So the hysterectomy and bilateral salpingo-oophorectomy is a good choice here, because even if you do whatever investigation, or by any chance if you are able to take one biopsy, but it is not going to be possible again and again, because anyway if you put her on a Mirena or any other drug, you have to do repeated biopsies, and you have already seen in the scenario that it is not possible for this woman, and she is very likely to have something bad. So yes, offer hysterectomy and bilateral salpingo-oophorectomy is the correct answer here. Got it? Why it is so? Why it is not A and why it is not C? Okay, the correct answer is hysterectomy and bilateral salpingo-oophorectomy. MRI cannot help you obtain the histology. So you cannot make a diagnosis. Good. Okay. 50-year-old patient with a BMI of 20 and one episode of postmenopausal bleeding presents to the clinic. She is otherwise asymptomatic. Abdominal and pelvic examination is unremarkable, and the endometrial thickness is 6 mm. Outpatient hysteroscopy and biopsy is arranged. The cavity is noted to be 8 centimeter in length and adequate sample is taken. Endometrium was noted to be atrophic at hysteroscopy and the cavity normal. At 2 weeks later, the histology reports read some inactive endometrium, but samples insufficient for diagnostic purposes. On reading the histology report, what would be the most appropriate action? Arrange MRI, arrange urgent hysteroscopy and curettage under GA, discharge the patient, recommend GP to start HRT, and review the patient in 6 months and repeat endometrial sampling. Okay, so 2 answers with C. C, okay. C, C, C. B, arrange urgent hysteroscopy, okay. Again C, again B. So 2 answers till now. I've got B and C. Any more answers? Okay. So let's discuss why B and why C. Okay, I have E also. Okay. So B, C, and E. Okay. So now look at this. What is the scenario? No risk factor. 50 years patient, BMI 20, just one episode of postmenopausal bleeding. Otherwise asymptomatic. So very nice patient, very healthy patient they have given you. No risk factor is there. Okay. Now endometrial thickness is 6 millimeter. You took a sample, but when you put a hysteroscope, you find that the endometrium was atrophic. And that is what appeared on the histology report also. Inactive endometrium, but sample insufficient, right? So what it is atrophic. So whatever histology report you got, that matches your hysteroscopic visual finding as well. So you believe that this is an atrophic endometrium, and you know that the patient is low risk. There is no risk here. So what you can do is you can take it as a case of atrophic endometritis, discharge the patient from the clinic and ask the GP to re-refer them should they have a further episode of bleeding. Why we have not chosen B, urgent hysteroscopy and curettage? Because you have just done a hysteroscopy and it was perfect. You find that cavity was normal, it is atrophic. So why urgent? No, your finding matches. Your visual finding and your histology matches. So no need of urgent hysteroscopy. Review the patient in clinic in 6 months and repeat endometrial sampling. But if it is a plain simple case of atrophic endometritis, we can't fix a 6 months rule, right? So that way we tell her to go back to GP. And if she has any repeated episodes, she can come to us again. What about D? Recommend the GP to start hormone replacement therapy. Hormone replacement therapy for what? Just for a single episode of postmenopausal bleeding? No, that is not an indication for HRT. For HRT, you have specific indications. She does not have any of those symptoms for which she wants HRT. So no. Okay, and when should we choose E? Okay, so we choose E whenever we follow the chart of endometrial hyperplasia. That is like we are putting patient on the treatment, then we choose it for the 6 months. There is no rule of just observation and doing a 6-monthly biopsy. Either you treat a patient or you discharge a patient. See, what could be the possible options here? Here you had atrophic. The other possible is you have endometrial hyperplasia without atypia, in which case you will be managing it with the Mirena and follow up at 6 months. If it is atypia, you are going for the abdominal hysterectomy and hysterectomy. So that way you have to answer. So there is no just plain simple observation on a 6 months period, right? Okay, ma'am, while treatment, simple HP and HP with atypia. With atypia, no. With atypia, if it is a hyperplasia, with atypia, then your answer in this patient will be hysterectomy right away. Because at 50 years, there is no family fertility preserving issue. Then yes. See, 3 months is also when you are putting that patient on oral progesterone or you are giving her Mirena. Then in atypical, you have to do 3 months. But in this patient, 50 years patient, fit patient, obviously you can choose surgery. So something will be mentioned. She doesn't want surgery right now or something like that. Yes, in that case, 3 months. Fine. So the correct answer is discharge the patient from the clinic because this is atrophic endometrium. No role in diagnosis, only a part of treatment. Yes, nothing like routine follow-up. Like in cervical screening smears, HPV positive, send back the patient and call after low risk, cytology normal, HPV positive, you say go back and come up for rescreening after 1 year. So that is nothing like here. No simple observation. You do it only for the test of cure. Okay, thank you. 66-year-old woman presents to the GP with 2 weeks of bleeding. Her last period was at the age of 54. Past medical history includes chronic hypertension treated with atenolol. She had 1 child at the age of 28 and is obese with a BMI of 32. She had a 2-week referral for gynecology outpatient where she had a pupil biopsy. The results of the later ultrasound and CT scan confirmed endometrial carcinoma confined to the endometrium with less than half of the myometrium invaded. She understandably devastated, but very keen to discuss management with you. Which of the following options is unsuitable within her current management plan? Okay, so very good. Everybody is answering C, radiotherapy, C, radiotherapy. Yes. What is the stage of disease here right now? Stage 1, yes. So this is stage 1. So of course, surgery is the one which is required here. Right now, there is no role of any radiotherapy. So everybody is correct?
Ma'am,
Why
ma'am,
not?
ma'am, I have a doubt.
Yes.
Ma'am, because this is stage 1A1 and endometrium stage 1A1 is the only cancer in which we can do the laparoscopic hysterectomy. So, and if it comes out to be grade 3, then radiotherapy has a role.
Yes, correct.
So why not A option?
Okay. So we are talking of what is unsuitable. What is unsuitable within her current management plan, right? So rest all things we need to do with this patient. Radiotherapy, maybe we need, because later on, if we do the histology and it comes out to be grade 3, we might need radiotherapy as well. But with her current management plan, right now, what you see from here, radiotherapy doesn't seem to be good option for her. So right now it is not so, but maybe after you do the surgery, you send a sample and then you find that this is a grade 3 disease and you want to give a radiotherapy, but that will be a later addition, not a part of the current plan. While the hysterectomy and all other lookout, all your staging techniques, they are part of the normal surgery, what you are doing. And of course, laparoscopy and abdominal both can be done for the patients. So if laparoscopy is the surgery of choice, but that doesn't mean that abdominal is contraindicated. Fine.
Ma'am, please can you repeat once again?
Yeah.
Why not?
Okay. Let me read this, and then if you still have a confusion, we'll again discuss, right? So the recommended primary treatment for stage 1 endometrial cancer is complete surgical staging, which encompasses laparotomy or laparoscopy with peritoneal lavage for cytology and careful inspection and palpation of the abdomen and pelvis. This would be followed by a total abdominal or laparoscopic hysterectomy and bilateral salpingo-oophorectomy as microscopic metastasis can be present. So all the other things we have to do. We have to do the inspection and palpation. We have to do the peritoneal lavage. We have to do hysterectomy either by the abdominal or the laparoscopic route.
Option D, BSO is not mentioned. That is also incomplete.
Yes, that is also incomplete. But then this is a concept of single best answer.
Okay.
Right?
Okay.
You have to choose one which is not at all matching or which is best among two. So you have to weigh radiotherapy or total abdominal hysterectomy. Right? So therefore, single best answer is you can have two very close answers to each other. Like you remember in the postmenopausal ward patient in the first, we discussed about the incisional biopsy and referred to CA, that cancer unit. Both were correct answers, but we have to choose what is more closer pertaining to guideline. Right?
Okay.
So radiotherapy is not at all required at this particular stage unless and until we are clear that this is a grade 3 carcinoma or a high risk carcinoma. Fine?
Yes, ma'am.
Okay. Good. 60-year-old postmenopausal woman who is using tamoxifen for breast cancer presents with history of postmenopausal bleeding. Transvaginal ultrasound showed an endometrial thickness of 5 mm. What is the best course of action? Gel installation sonography, outpatient, hysteroscopy with targeted endometrial biopsy, pupil biopsy in clinic, repeat ultrasound after 8 weeks, and saline sonography. B. Okay. B. Okay. So everybody wants to go with B, right? Yes. So very clear rule, and this is very important. You will find a question of tamoxifen patient with postmenopausal bleeding, right? This is a very commonly asked question. So basically, any symptomatic patient on tamoxifen, you will require outpatient hysteroscopy with endometrial biopsy. What is the cutoff for tamoxifen in asymptomatic patient? In asymptomatic patient on tamoxifen, whatever thickness is there, you are not going to take any biopsy. You are not going to take any biopsy. It is only in the patients where you are symptomatic, then you have to take the biopsy, and that too hysteroscopic biopsy. Why? Because tamoxifen leads to stromal changes. There is edema, right? There are cystic edematous changes in the endometrium. So if you do the hysteroscopy, then you will find abnormal, and the normal endometrium will look like a malignant endometrium. So there will be not a clear diagnosis. So therefore, you do it only on the symptomatic patients, and no people's always hysteroscopic biopsy because of the tamoxifen induced changes in the endometrium, which can confuse, which can make you confused and actually give you a false diagnosis. So symptomatic patients on tamoxifen, you will do outpatient hysteroscopy with targeted endometrial biopsy. 7 mm is not a correct answer for this particular scenario. No. That is about HRT. In HRT, if you have thickness more than that and there is a bleeding, then you will do the biopsy. But that the 7 mm figure is not true for tamoxifen. In tamoxifen, you may find 20 mm in a normal patient without any symptoms, nothing to be done. Fine? Difficult to digest, I think, but it's true. Yeah. Okay with everyone? Any confusion, just let me know. We'll clear it here only, because this is a very important question and this rule comes again and again in the exam. Right?
Ma'am, can you repeat regarding HRT?
Regarding?
HRT and 7 mm thickness.
Actually, I couldn't get you. Your voice is breaking.
So ma'am, in this like endometrium thickness, if like tamoxifen is used for breast cancer, so any thickness will not matter for biopsy.
Asymptomatic patient, no.
Yes, and if the patient is on HRT with tamoxifen, then 7 mm is the cutoff.
Plain HRT. Why
Okay.
HRT and tamoxifen? Tamoxifen breast cancer patient, would you prefer HRT?
No.
So I'm not talking of HRT with tamoxifen.
Okay.
I'm just talking a patient on HRT.
And symptomatic, if the patient is symptomatic with tamoxifen, then like any thickness.
Yes, then even this is 5 mm thickness, still we are doing hysteroscopic biopsy.
Okay, thank you, ma'am. Thank you for clarification.
Ma'am, in case the thickness is given 3 mm, then also biopsy?
Or patient on tamoxifen with symptoms, yes.
Okay. Yeah, with symptoms 3 mm thickness, still biopsy?
Still biopsy. Any patient on tamoxifen with symptoms, biopsy. That too is hysteroscopic biopsy. Never pimples.
Okay, ma'am. Is there any reference for tamoxifen who is asymptomatic with any thickness, nothing to be done? Is there any reference?
Yeah, I'll post that.
Okay, okay. And secondly, ma'am, one thing that is related to tamoxifen, like it is said in breast cancer, if the patient is on chemotherapy, we ask them to avoid pregnancy after 2 years of completion. But if in breast cancer patient is on tamoxifen, is it so that for tamoxifen, for breast cancer, we just ask for 3 months patient to not get pregnant, not 2 years?
No, actually, that's a totally different thing, because there is a that 2 years concept is right. Basically, for 2 years she should not conceive. That 3 months is like
If she is
there's a difference in the language actually. That is only the RCOG plays with the language. Therefore, the answer is 3 months, and somewhere the answer is 2 years. That is how the language is, right? But actually, patient should not get pregnant for 2 years.
So, ma'am, for tamoxifen and breast cancer, what to choose? 3 months or 2 years?
2 years.
2 years. And when to choose 3 months with tamoxifen?
There is one recall on that. I'll post that recall. That is a different language. Just now, it's not clicking my mind, but
Okay,
that
ma'am.
that is different. The language is different.
Okay, ma'am. Okay.
Yeah, I'll see that and post. Right now, it's not coming to my mind. That there are two recalls actually. There is a difference in the language there.
Ma'am, I think there are two scenarios.
Hello, ma'am. Hello, ma'am.
Yeah.
Ma'am, if the question comes like if the same question comes and they say that the patient is asymptomatic and she has an endometrial thickness of like 10 mm, then what would be the answer?
Nothing to be done.
Okay, thank you.
Asymptomatic patient, nothing to be done, and those who are asking for reference, I'll post that.
Excuse me, ma'am. Asymptomatic, even with the high risk factors for endometrial carcinoma like obesity, hypertension, diabetes, and all, still endometrial thickness more than 10 or so. Still no investigations, ma'am.
Asymptomatic patient on tamoxifen, no investigations. Why we are doing? Because you understand the basic concept behind it, then you will not be confused why it is so. Because it is already causing all the changes in the endometrium, which are benign. But if you take a sample and you look into it, you may mistaken it for the malignancy, and then patient will be overdiagnosed. Therefore, we do not do in asymptomatic patients the further investigations. We don't want to overdiagnose.
Okay, not like tamoxifen. Even not on tamoxifen also, we will not interfere. Like routine scan, for other reason we have done scan and we have...
I am just talking of tamoxifen patient with increased thickness. Asymptomatic we will not do. I am not talking of other scenarios. I'm talking of in tamoxifen. On the other hand, I'm saying if patient is on HRT, you have 10 mm thickness. Yes, you would like to look at the sample, whether it is ATP or something is there. In that case, you will look at it, but not for tamoxifen. I think people have answered here that 3-month scenario also. Before pregnancy, no tamoxifen for 3 months. So it is, yeah.
And there are two scenarios regarding tamoxifen. One is if the patient is using tamoxifen for breast cancer, then you have to avoid pregnancy for 2 years. But if the patient is taking tamoxifen for any other reason, other than breast cancer, then the contraception should be for 3 months, I guess.
No, the person they here in the chat box, they have mentioned it very nicely that you have to stop at least 3 months before planning a pregnancy. Okay, but if patient is on tamoxifen, you will not allow, you will tell her not to conceive for next 2 years. But when you stop at least after 3 months, then she can conceive. You understand the difference between two? Patient is on tamoxifen, you tell her that for 2 months she should not conceive. But when she plans to conceive, she should have stopped at least 3 months before tamoxifen. But 3 months prior, she should have stopped tamoxifen.
Got it, ma'am.
Got it? So what I said, they just play with the words. If you don't read those words properly, you will mistaken. And thank you for writing the correct sentence here. That sentence was not clicking in my mind, but very nicely people have mentioned in the chat box. Great. Fine. Now everything clear? Tamoxifen is not scary as we all believe when we answer questions. I think tamoxifen is the simplest to answer. You just need to have a clear rule in your mind. And this question you can very well score. Okay, so the answer is outpatients with all abnormal bleeding or spotting should be investigated, right? But people endometrial biopsy rarely provides the diagnosis. So therefore, this is done, okay? So symptomatic women with a thickened endometrium should be investigated with hysteroscopic and a targeted biopsy. Clearly written in Stratog itself. Only symptomatic patients to be monitored. No asymptomatic. This is a flow chart which we follow for the postmenopausal bleeding. History and examination to include abdominal palpation, speculum examination, vaginal examination. So you rule out, first do history, do examination, then define transvaginal ultrasound. Less than 4 mm, it is atrophic, discharge. If there are persistent symptoms, go for Pipple biopsy. If endometrial thickness is more than 4 mm, Pipples is the rule. It is benign, fine. If hyperplasia or malignancy, we follow the guidelines. If inadequate or not possible, then do the next step, that is hysteroscopy, OPD hysteroscopy. If it fails, do the hysteroscopy under GA, right? So all the pathways go through the Pipple biopsy. Now, what are the 3 scenarios where we do not do Pipples and we directly go for hysteroscopy? What are the 3 scenarios?
If an scan found fluid in endometrial cavity, number 1.
When there are high risk factors and there is like erratic endometrium, like the endometrium is very irregular.
And fluid in the endometrial
And we suspect
cavity.
polyps and treatment.
Yes, polyp is correct. Good. Another?
Tamoxifen and irregular lesions on ultrasound.
Obese patient and like diabetes type with type 2 diabetes.
No people for that. Only irregular focal lesions on ultrasound. If we suspect polyp on ultrasound, and the third thing is
focal lesions and polyp comes in one category. Any structural lesion you are suspecting in endometrium, then you will do direct hysteroscopic biopsy. Second is tamoxifen. And third is where your Pipples fail.
And high BMI.
Only these scenarios.
Ma'am, what about double layered endometrium, fluid in endometrium?
Okay. Double layered endometrium and fluid in endometrium is mentioned in TOG article, but not in Stratog. Double layered endometrium, fluid in endometrium is mentioned in the TOG article, right? But it is not mentioned in the flow charts of Stratog. So if you have other options, other good options which come from 3 basic things, three are basic, right? Tamoxifen is basic, your structural defects in endometrium is basic, and failed Pipple is basic. These 3 are the predominant one. See, you have a concept of absolute contraindication and relative contraindication. So if you have options of absolute and relative, which one you will choose? If you are asked about the contraindication, you will first go with the absolute, right? Makes sense? Similarly, see, these 3 are the basics. If you don't find these 3 in your option, then if you have double layered fluid, you can choose that if these 3 are not in the options. But if these 3 are in the options and you have to choose one, you will prefer choosing from these 3. right?
Yes, ma'am.
Okay, okay, great. This is the treatment chart, okay? So this is the treatment. Surgical, we have to do 1A, simple total hysterectomy, bilateral salpingo-oophorectomy. Then you can go with the bulky fibroid uterus, laparotomy, THBSO, and laparoscopy can be done, robotic surgeries can be done. All routes are feasible for stage 1A and grade 1 endometrial cancer, and even vaginal hysterectomy is a good option if there are significant comorbidities and you desire to reduce the anesthesia impact. Then even vaginal hysterectomy can be done in these patients.
Ma'am,
Stage.
I have a last question. Yes, ma'am, as you said that if patient is on tamoxifen and patient is asymptomatic, then we will not see the thickness and we will not go for biopsy, right? But if
No.
the patient is on tamoxifen, patient is but she has comorbid, like patient is diabetic, hypertensive, then we will go for biopsy on.
No.
Still not.
No. There is no rule of doing biopsy in asymptomatic tamoxifen patient.
Okay.
Okay, stage 2, radical hysterectomy plus minus lymphadenectomy plus minus radiotherapy. Stage 3, TH with BSO plus radiotherapy. Stage 4, surgery plus radiotherapy plus chemotherapy can be done. Okay, 38-year-old woman with intermenstrual bleeding had an endometrial biopsy that has been reported as simple hyperplasia. What is characteristically associated with this diagnosis? Very easy question, direct question. Yes, A is the correct answer, and ovulatory cycles. Oh, you are giving a talk to the medical students on endometrial cancer. A student asks what the incidence of endometrial cancer is in UK. With what figure do you answer the question? It's a figure, so if you know, it's fine, else we can discuss. No clue. Yes, it is 9,000 new cases per year. Okay, so 9,000 new cases per year are there in UK every year. Endometrial cancer is known to be associated with certain lifestyle factors. What percentage of endometrial cancers are thought to be preventable? D 25%. No, actually it is 34%. Right? So Stratog mentions it as 34%. So E is the correct answer. Yes, 34 is the correct answer. Good. Okay, when considering mortality with regards to endometrial cancer, which of the following statements most closely represents mortality rates in UK over the last 10 years? A. A is the correct answer. Yes, very good. If you know this answer, that's really hats off. Increasing mortality rates over the last decade by approximately 25%. So that is a correct answer. Okay. Now, two questions, two EMQs we are going to solve about the ovarian cyst, because Stratog did not had any question about the ovarian cyst, surprisingly. So I had taken this from the book. So let's solve this. 60-year-old postmenopausal woman is seen in the clinic for follow-up after she had a transvaginal ultrasound scan as part of investigation for vague lower abdominal pain. Scan shows a left unilocular simple ovarian cyst measuring 45 into 35 into 50 mm. She is otherwise asymptomatic. What is the single most appropriate next step in their management? Yes, I, 3I, 4I, W, I. Okay. So correct, CA 125 is the correct answer. I is correct answer because you have just done the ultrasound scan and looked at it. But to calculate the RMI score, postmenopausal women, ovarian cyst, anything above 1 centimeter, we have to look for RMI score. So to look at RMI, we need CA 125. So I is the correct answer. Measure CA 125. Then 59-year-old postmenopausal woman is seen in gynecology clinic after she was referred by her GP with what is suggestive of irritable bowel syndrome over the last 12 months. Medical treatment has been ineffective. She has a family history of ovarian cancer in her mother who died 8 years ago. Again, I, okay. W, ultrasound scan and CA 125, okay. See, a patient has come to you with some complaint. So what else we can do? Yes, F is the correct answer. Very good. Full physical examination. First, you have to rule out if there is any abdominal pathology or what is happening. So first, history. In history, you got the symptoms. Then you go for the examination and then physical examination, and then you go for the further steps of investigations. So F is the correct answer here. Full examination, full physical examination is correct. Ultrasound scan was performed on a 60-year-old postmenopausal woman with a suspicious pelvic mass on abdominal examination as part of investigation for vague new onset symptoms, and CA 125 level was reported as 356 international units per ml. Scan is reported as complex multiseptated left ovarian mass measuring 61 into 45 into 67 with associated ascites in the pelvis. What is the next appropriate step? B. Yes, B. Everybody B, and it is correct because here RMI score is going to be more than 200. So patient has to be referred to gynae-oncology, and there is a step in the guideline. Before we go for the gynae-oncology, we do a CT scan. So CT scan is a correct answer. B is a correct answer. 60-year-old woman had an ultrasound scan arranged by a GP 1 year ago, and it demonstrated a 40 mm unilocular ovarian cyst. She remained asymptomatic but has been referred for a reassurance ultrasound scan 12 months later, which shows that the cysts have remained unchanged. Now what to do? QPP CA 125. Yes, CA 125 is the correct answer because you rescreen the patient, you reevaluate the patient, but your evaluation includes ultrasound as well as CA 125. So here, when the patient has come up for after 12 months, you have done only ultrasound scan. So to get a complete picture, you need to do ultrasound scan and CA 125. So CA 125 is yet to be done. So therefore, the correct answer is CA 125. Correct? Okay, so that was all the answers, and these are the references from the guidelines. So a full physical examination, see if any. See, RCOG is like your comprehension passages. You have to choose exact sentences from your green top guideline and answer accordingly. So you see that on the top line, there is 12 months. irritable bowel syndrome, and you do a full physical examination. So that is where your answer is. Right? Here it is RMI, after that CT scan, and this is repeat assessment which includes CA-125 along with ultrasound. Right? So all your references was mentioned in the question. Then you can do once again repeat assessment. See here the chart. Repeat assessment in 4 to 6 months. If it is unchanged, you can do a repeat assessment. After that, treatment is individualized. So in that case, there is a question I've seen somewhere in which they have mentioned that CA-125 is still normal, but it has increased. Okay. So in that case, you choose further surgery. So it is individualized. Okay. So another question. 39 scan was done at 12 months in this case. Yes. So see, RCOG has given you this scenario. So we cannot tell them that it should have been done at 4 to 6 months. So you haven't framed a right question. So whatever information is given to us, we have to solve that. So after 12 months, if both the things are normal, then the things are individualized. So as I am telling you, there is a question in which they have mentioned that CA-125 increased from 20 to 25, or size increased from this centimeter to this centimeter. And in that case, you will choose definitely surgery. But if everything is same, then it is an individualized treatment. Okay. So 39-year-old woman presents with the abdominal pain of 2 weeks duration. The pain that was initially mild and not requiring analgesia has not disappeared. She is a mother of 2 children and is otherwise healthy. GP requested for ultrasound scan, which showed a simple cyst of 42 into 48 millimeters in diameter. At this particular stage, 42 into 48 less than 50. So, no, less than 50, you can just discharge the patient. Premenopausal ovarian cyst GTG. Less than 50 mm, you discharge the patient. Reassure and discharge from follow-up. So M is the correct answer. 35-year-old woman is referred for ultrasound scan on suspicion of an adnexal mass after a pelvic examination for irregular periods. The scan shows 50 into 60 mm complex right ovarian cyst with no fluid in the pelvis. JLJ. Okay, so what is JLJ? Right, so J and L, the difference is of CA-125. J is correct. You do all CA-125, alpha-fetoprotein, HCG, and LDH. So J is the correct answer here. Complex cyst, less than 40 years, you have to do all. So all 4 hormones to be, tumor markers to be done. 45-year-old woman was referred by her GP with an ultrasound scan showing a left ovarian cyst that measured 16 to 60 mm in diameter. There was no fluid in the pelvis and CA-125 level is 150. A 45-year-old woman was referred by her GP with an ultrasound scan showing a left ovarian cyst GEF. F, laparoscopic salpingophractomy. G, MRI. E, laparoscopic ovarian cystectomy. Okay. So in this case, the female is, see, surgery is above you recommend surgery definitely above 70. Yes. So in this case, it is 60 by 60. So one thing is that, and then your CA 125 is 150. So for referral to gynae onco is CA 125 level should be more than 200. Below 200, you have to assess the patient for any other pathology which is leading to CA 125 raised levels. So you have to work on other things like this can be a endometriosis. So therefore, you have to do MRI. You have to do MRI to assess it further. So guideline says that below 200, you have to assess. So if serum CA 125 is raised and less than 200, further investigation may be appropriate to exclude or treat the common differential diagnosis. So therefore, you have to go and do the other imaging. So MRI is a good option here. 42-year-old woman was referred to the gynecology clinic with the vague lower abdomen discomfort. Ultrasound scan is performed and she is found to have a 70 mm complex ovarian cyst. 125 level is assayed and is reported as 250. Of course, everybody knows the answer. Yes, N is the correct answer. Refer to gynae oncology unit. Correct. This is the sources from the guideline. Okay. Okay, what stage is shown in this image? We are talking of this first image, ovarian cancer.
Stage 2 in first picture.
Okay.
And stage 4 in second picture. No.
Yes, correct. Stage 2 in first picture and in second picture.
Again, stage 2 in second also because it's the intraperitoneal. Everything
Good.
is
Very good. Very good.
Intrapelvis.
Yes, correct. So it is basically both are stage 2, right? So
Yes.
remember it as stage 1, it is ovary. Stage 2, it is pelvis. Stage 3, it goes into abdomen. And stage 4 is distant.
Yes.
Okay, so the easy way to remember is stage 1 is ovary, confined to the 1 ovary, 2 ovary, and all those things. So ovary, stage 2 is pelvis. Okay, then stage 3 is it goes into abdomen, and stage 4 is distant. So these both are stage 2 images. Now this one we just talked of.
Stage 4B because pleural effusion is also there and it's still kidney. It's liver mets is
Stage 4.
and the liver capsule is stage 3 in the second picture. Cirrhosis is stage 3, I guess.
Yes. Parenchyma is stage 4.
But why are you saying stage 4 in this first picture? Where is pleural effusion?
Ma'am, ureters are also involved.
Stage 3.
This is stage 3 only. These are the meds. You see on
Yes,
the
ma'am.
bowel, here, and here on the diaphragm. So it is not gone into the chest. It has not involved the liver, that parenchyma or anything like that. So this is also stage 3.
Yes, both are stage 3.
This is stage 3. This is also stage 3 because capsule is involved. So both of them are stage 3. Here.
Stage 1C.
Right. 1C.
The other is stage 4A.
Yes. It is parenchyma is involved. So now this is stage 4. Correct. What is shown in this image?
Stage 1B and the other is stage 1A.
Correct.
Both
Both
are-
is confined to ovaries. So it is stage 1. Correct. Okay. Now let's come to questions. 60-year-old postmenopausal nulliparous woman is referred by her general practitioner with the sensation of abdominal bloating and complaining that her clothes no longer fit. The general practitioner also found a pelvic mass on examination. She is referred for urgent assessment to her local district general hospital. She has a personal history of endometriosis, but no significant family history. Following your history and examination, you remain suspicious that the woman may have an ovarian tumor. Which of the following investigations are most suitable for women referred to secondary care with suspected ovarian cancer? Pick the single best answer.
Ma'am, chest X-ray, CT, abdomen and pelvis at secondary care. Ultrasound and CA 125 are at primary care at the GP level.
So what is the answer here?
B.
Yes. Anyone else with any different answer, or everyone agrees with this?
Why not C?
Why not C? Yes. Why not
That's
C?
at the primary level. If the patient approaches the GP, he orders an ultrasound and does the CA 125. And then because this patient has been referred to a secondary care where already we go for X-ray and CT. I may be wrong also, but this is my concept till now.
I
Yes.
think initially we do TVS plus C or 95. Then we will jump to chest X-ray and CT. Isn't?
Okay. So basically, now what she is saying is right. Basically, they have specifically mentioned that patient has been referred to secondary care. So what they are actually asking is, what are to be done at secondary care? You read the question. Which of the following investigations are most suitable for women referred to secondary care with suspected ovarian cancer? So they have given you a scenario. This is how RCOG plays, right? They have given you a long scenario. They have not given you ultrasound and CA 125, right? So immediately you think that first we have to do CA 125 and ultrasound. But now you read your question. Which of the following investigations are most suitable for women? Not talking of this patient. For women referred to secondary care with suspected ovarian cancer in general. What do you do in secondary care? So in general, we do in secondary care the chest X-ray and CT and further tests. Because pelvic ultrasound and CA 125 we have done in the primary care. You read this question again and you will catch hold of why the different answer is here. Which of following investigations are most suitable for women referred to secondary care with suspected ovarian cancer? They didn't ask you what investigations we need to do for this patient. Right?
Yeah.
Yes. So you have to read. Many a times it is so. The whole scenario is different and the final question which they ask is very different. So always pay attention to the last sentence. What is the question they are asking? Okay, so this is about the secondary care. Which of the following best describes known side effects of paclitaxel?
Ma'am, it doesn't cause thrombocytopenia.
Yes,
So
very good.
that rules out the last option.
Hmm.
Then there is no cardiac effects. That rules out the second last option.
Very good.
Neurotoxicity is definitely there. Arthralgias, hypersensitivity reaction. Third option is also ruled out because there is a thrombocytopenia. So last three options are ruled out. Between first and second, I guess the second one, because diarrhea is also not a complication, because neurotoxicity is definitely there.
Right.
Alopecia,
It's absolutely correct. B is the correct answer. And the way you came to the answer, that is also a very good thing. Because when in questions like this, where you may not be remembering each and every point, it is good to remember whatever points you have, you can define the answer accordingly. So perfectly solved question. This is a B. Alopecia, nausea, vomiting, neurotoxicity, arthralgia, hypersensitivity reaction, nephrotoxicity, and neutropenia. Absolutely correct. And you gave the complete explanation why it's not thrombocytopenia, it's not diarrhea, then no cardiac effect. So therefore, all the other options are ruled out. So B is the correct answer. Which of the following best describes the contraindications to paclitaxel therapy? I think I should answer this question. So D is the correct answer. Severe hypersensitivity reaction to paclitaxel or excipients and lactation, neutrophil count less than 1.5 into 10 to the power 9. So D is the correct answer, which is the contraindication to paclitaxel therapy.
Why not creatinine clearance? Because it's nephrotoxic also.
But the complete thing, we have to look at the complete scenario. So this is the one which perfectly suits according to the neutrophil count and everything here. So therefore, this is the correct answer. Which of the following best describes the known side effects of carboplatin?
Ma'am, B option. Alopecia, thrombocytopenia, nephrotoxicity, arthralgia.
Arthralgia is a feature of paclitaxel. Okay. Arthralgia, myalgia are features of paclitaxel. So D is the correct answer here because carboplatin thrombocytopenia. So thrombocytopenia, nausea and vomiting, hypersensitivity reactions, nephrotoxicity, and neutropenia. So D is the correct answer. A is not correct. Adverse cardiac effects is not there. Arthralgia is not there. So B and C not correct. D, neurotoxicity is not there. Neurotoxicity is a feature of paclitaxel, not with the carboplatin. So D is the correct answer. 1 point, what you asked about the creatinine clearance. So basically, it should be less than 30 ml per minute to have that effect of renal failure. So it is 100 here. In next question, when we will talk about the carboplatin, here you see it is 30 ml and we will choose this option where it is 30 ml. Okay. So this is about the carboplatin contraindications. So contraindications for carboplatin is creatinine clearance less than 30, history of severe allergic reaction to platinum containing compounds, severe myelosuppression and bleeding tumors. Why bleeding tumors? Because of the thrombocytopenia. So therefore, contraindication to carboplatin are the creatinine clearance less than 30 ml per minute, history of severe allergic reaction to platinum containing compounds, and severe myelosuppression and bleeding tumors. Okay, so the treatment of fallopian tube carcinoma is similar to which other gynecological malignancy?
Ovarian.
Yes, correct. Ovarian. Good. They are both categorized in a similar group. So which adjuvant therapy has the biggest role in the treatment of fallopian tube carcinoma?
D option.
Okay, carboplatin and paclitaxel. So basically, they are just asking what adjuvant therapy. So chemotherapy would be a better answer because then whatever drugs we use, they will come in the chemotherapy. So chemotherapy is a bigger blanket word to include, to be included as the term adjuvant therapy, because adjuvant therapy can be with radiotherapy, with chemo-radio or chemo hormonal therapy. So what modality of therapy you are adding? So the chemotherapy is the better answer.
But ma'am, we give specifically carboplatin, paclitaxel. So better not D option because chemotherapy has many, but if for ovarian,
See, if I ask you what are the modalities of adjuvant therapy, would you say carboplatin and paclitaxel?
for epithelial,
No.
majorly,
If my question is what are the modalities of adjuvant therapy?
okay, it includes web therapy
Yes.
also.
So you
But
have to no, how do you categorize adjuvant therapies? You do not categorize adjuvant therapy as carboplatin and paclitaxel one group, BEP as other group. You don't classify it like that.
okay,
Or
okay.
you don't classify adjuvant therapy as brachytherapy or teletherapy. You classify them as chemotherapy, radiotherapy, chemoradiotherapy, neoadjuvant therapy, palliative. So like this we do classify. So accordingly, it is chemotherapy. Now come to this question. This will make you more clearer. When chemotherapy is indicated, which agents are most commonly used as first-line treatment?
D.
Now you are correct with carboplatin and paclitaxel. So you take the difference between the two questions, right? So in that case, they were asking about the modality. What modality we can use? Okay, regarding fertility sparing surgery in ovarian cancer, select the single best answer below.
Sorry, C option.
Okay, yes, C. C. Everybody is okay with C? Yes, C is correct. C is correct. Germ cell tumors are best managed by fertility sparing surgery and chemotherapy. That is the correct. Why others are not correct? Because in this, we need to take peritoneal washings also. So A is not a complete statement. Fertility sparing surgery should be performed only in women under 30. This is wrong. Metastatic ovarian cancer, even you can do fertility sparing surgeries if fertility is the requirement. CA125 and beta HCG, not important. Okay. What is the correct FIGO staging? Tumor in ovaries, pelvis, para-aortic lymph nodes with microscopic spread to omentum.
3C2.
Okay. Everyone? It is pelvis, para-aortic lymph nodes with microscopic spread to omentum. Okay, so the thing is, they haven't given you the size. It is basically how it is. Lymph node metastasis and peritoneal metastasis. That is how you classify them as. So extra pelvic, you are going here. So you have this as a stage 3C. Right. Tumor in ovaries and omentum less than 2 centimeter. 3B. 3B. 3A is microscopic. 3B is less than 2 centimeter and more than 2 centimeter is 3C. Tumor in one ovary, positive washings. 3 Okay, I forgot to look in the chat box. Sorry. 1C3. Yes, correct. 1C3, correct. No, this is 1C3. Sorry. 3B is not the correct answer. 1C3 is the correct answer. Tumor involving ovaries and pelvic peritoneum, negative washings. Yes, stage 2. Stage 2 is the correct. Involvement of both ovaries, negative washings. I think we have done enough of practice of this staging. Okay, so you want to revise stage 3, right? So stage 3, we have stage 3A, 3B, and 3C. So 3A is lymph node. See, remember it as A is microscopic, B is up to 2 centimeter, and more than 2 centimeter is the C, right? So A, it is microscopic, you cannot see. B, you can see with a magnifying glass, and C, you can see with your open eyes. Okay, so if you remember this, you will remember it. So lymph node involvement. So metastasis less than 10 millimeter, that is less than 1 centimeter, or more than 1 centimeter. Then you have 3B, which is extra pelvic and peritoneal spread less than 2 centimeter, and 3C is extra pelvic peritoneal involvement more than 2 centimeter. So just remember microscopic, less than 2 and more than 2. Okay. 15-year-old patient presents with the left lower abdominal pain. The transvaginal and transabdominal ultrasound scan shows a 15 centimeter solid ovarian mass. LDH is elevated with the normal alpha-fetoprotein and human chorionic gonadotropin. What is the correct? Yes, dysgerminoma is the correct answer. Very good. 19-year-old woman undergoes surgery for the unilateral pelvic mass. Intraoperative findings show implants on fallopian tube, and cytology confirms malignant peritoneal washings. Histology confirms a granulosa cell tumor. CT imaging excludes nodal involvement or distant metastasis. What is the correct FIGO staging for this woman? Yes, in the chat box. 2A, 2A, 2A. Very good. Now you all are good with the staging. Very good. 32-year-old patient presented with the sudden onset of right lower abdominal pain. Transvaginal scan shows a 7 centimeter right ovarian cyst with protrusion arising from the inner surface of cyst containing hair, teeth, and fat. What is the most likely diagnosis? Very easy question. Yes, cystic teratoma. Yes. 16-year-old with the left ovarian mass undergoes surgery and is diagnosed with stage 1C yolk sac tumor. What is the most appropriate chemotherapy regimen? B. Correct. It is the BEP regimen, which is correct answer. Good. 25-year-old woman who is para 2 was treated with surgery and chemotherapy for stage 1C dysgerminoma. She is anxious about the future and during a follow-up consultation inquires about the chance of seeing her children grow up. So what is the survival? Estimated 5-year survival. When POM in a higher grade carcinomas, the POM is used. So what is the survival rate? It is 70%. 70%, right? So 70% is the correct answer, which is the, it is 90%. 90%, the correct answer is 90% for patients with germ cell tumors requiring chemotherapy. They have a long-term survival of approximately 90%. 20-year-old nulliparous woman received surgical treatment and chemotherapy for stage 1A yolk sac tumor. She is keen to start a family in the near future. What is her chances of successful pregnancy? Yes, now it is 70. Good. Very good. It is 70. 24-year-old woman was seen for a rapidly growing abdominal mass and abdominal pain. Further radiological investigations and the tumor marker panel suggest an endodermal sinus tumor. Her case is being discussed by the gynecological oncology multidisciplinary team panel. Which of following is the best management in this case? "24-year-old woman." See. Yes, correct. So the surgical exploration, unilateral salpingo-oophorectomy with either adjuvant or therapeutic combination chemotherapy. So that's a correct answer. 16-year-old presented to the pediatric gynecology clinic with progressive abdominal distension of 3 months. Her transabdominal scan showed unilateral cystic solid 12 centimeter mass. What tumor markers would you request? 16-year-old patient. What tumor markers you request? B, D, B, D. B is the correct answer. So you have to do all of this and then you add inhibin B and AMH also. Okay, in less than, in these young patients, adolescent patients, you have to add inhibin B and anti-Mullerian hormone also.
Ma'am, inhibin B is for granulosa. Why AMH and calcium?
These are for, because the tumors, in this case, they are basically from the embryological components. Okay, so sometimes you are not able to define what is the clear embryological component behind it. So therefore, these are present in embryologically derived tumors also show these tumor markers. So therefore, we do for these, because all these tumors which are present in this age group are from the embryological tissue. So therefore, these markers are important in the detection of these tumors as well. So B is the correct answer here. Okay. That's it. It was a long session, but I hope you enjoyed. Good, better, best. Never let it rest till your good is better and your better is best. So people always ask you what else we can do. So we have to keep working till we achieve our goal. And of course, MRCOG courses helps you in doing that. Your questions and your feedbacks are always welcome. Okay. Thank you. Good night and take care. Bye-bye.